Thank you very much for inviting me, Stanley especially. When he first asked me, I said yes immediately because over 30 years ago I was married here, and so it always brings back good memories to come. And then he told me what he wanted me to talk about, and I said, are you sure? Because this is not it is heartwarming work, but it's not the most uplifting talk. So anyway, I hope you eat your chocolate brownies in front of you, so that'll make you feel a little bit happier. But this is very serious work, and I wanted to give you a little background. Okay, so these are my views, not the views of the NIH. This is my disclosure. I wish I had some financial things to disclose, but I do not, unfortunately. And the objectives of tonight are for you to be able to identify at least 3 roles of a pediatric consultation liaison psychiatrist, which is what I am, and to be familiar with advanced care planning guides for adolescent and young adults. So a consultation liaison psychiatrist has changed its name a few times, last called psychosomatic medicine, but that person is called to help you all determine in your medical settings, is the person in front of you having a psychiatric disorder? And if so, is the psychiatric disorder a direct consequence of a primary medical condition, such as being depressed before pancreatic cancer? Is it depression secondary to interferon being given? Or is it a primary psychiatric disorder? Did they have bipolar disorder before you gave them that medication? Or is this sadness and anxiety a psychological reaction that's appropriate to having learned they have a chronic serious medical illness? So we try to help determine that. And in pediatric consultation liaison, which used to be called pediatric psychiatry by Leo Connor, who was the first child psychiatrist at Johns Hopkins in a pediatric hospital. He was a Harriet Lehner, like myself. We try to strive to ameliorate the adversity of being chronically or seriously ill, and we have an obligation to try to facilitate proper development, optimal development in children, which sometimes means consulting on the parents, actually. And then we also actually have the added benefit of trying to prevent mental illness before it actually comes out. So just to remind you of the developmental trajectories that we're interested as pediatricians and child psychiatrists, physical growth is frequently affected by children with medical illnesses. They're often small for age, and don't develop as quickly. Motor development, language, as separated from cognitive development, it is a good marker for cognitive development, but it doesn't mean it's not exactly the same, and some children who have great receptive language, as in HIV, may not have good expressive language. And then we also evaluate cognition and emotion and attachment and sexual development. And these are some of the typical developmental trajectories that kids have. You see, even within normal, there is a wide variation. And then there are kids who are developmentally delayed, so-called, but they kind of catch up. And then we see kids who plateau. So maybe you've had brain cancer and you get radiation and you really can't continue to develop as well. And then we also see regression. Maybe you have a storage disease and you actually regress, right? So these are all the ways we look at children. And this is a little bit hard to see, but I just remind you, this is Erikson's psychosocial stages. And these are the tasks that we must all go through as we develop psychosocially. And you see trust, we start with trust and autonomy and initiative and industry identity. So from 0 to 25 covers this much of the table, okay? And then Erikson kind of just said everything over 30 to 90 here is just generativity. But we all know actually that people your age and actually have development also and have milestones and accomplishments. So my mother-in-law, who wrote a book called Lighter as We Go about the virtues, character, strength, and aging. So it's a book about seeing the positive side of aging. She was 87 when she wrote it. And she modified Erickson's table so that it wasn't just about the kids, and you see there's adult, which he left one step for, and then there's young, old, and oldest of old, which is living beyond 90. So just to say that there's a lot more development that goes on after 50, right? And we still have milestones to achieve, but you do see there's a little difference in gradual increase in ability to control the environment as opposed to gradual acceptance of the limits of what is possible. So we're always developing. But when you're sick, how is that affected? So I'm going to focus on cancer because that's what I focused on when I came to the NIH in 2002. I had been focusing on HIV at Children's Hospital. But when I came to NIH, we had been so successful in curing kids of being born with HIV that there was no longer a need for an HIV program, pediatric HIV program at the NIH, and that closed with the success of AZT. So I met a social worker named Lori Weiner, and she was working in childhood cancer. So at the NIH, we see a lot of cancer. Childhood cancer is increasing globally. It's the leading cause of death by disease. The other area that I work in is suicide, so I'm just trying to keep kids from dying or trying to help them die gracefully. And that's the second leading cause of death in kids at all levels, but by disease, it's cancer. Cancer affects all ethnic, gender, and socioeconomic groups. There are 300,000 new cases of cancer in children every year around the world, and 215,000 of those are in kids under 14, so we have a lot to do with kids who are developing, and about 85,000 kids between the ages of 15 and 19. So this is a childhood cancer survival graph, and you can see that I would say my father-in-law, who won a Lasker for working on combined chemotherapy for leukemia in children, we've gone from no survival to over 80%, almost 90% survival. So this childhood cancer is an amazing success story, but we still have then the residual psychosocial issues that they have if they survive, right? Now, not everyone survives, though. So every day, 43 kids are diagnosed with cancer. The average age is 6 years. More than 40,000 kids undergo treatment for cancer every year. 12% of those kids will not survive. And of the 60% who are surviving these days, there are now late effects from they're getting infertility, heart failure, second cancers. And there are now, and this is a growing population, as you know, even in adults, there are 375,000 adult survivors of childhood cancer. That's not mentioning the millions of adults who are surviving now. So 1 in 530 adults between the ages of 20 and 39. So in the last decade, pediatric palliative care has become its own specialty also. So child psychiatry and pediatric palliative care have a lot of overlap. And so we often are seeing the same patients, and we're all providing emotional support. We're all worried about quality of life in children, delirium, uncomplicated depression and anxiety, end-of-life priorities, bereavement, spiritual support, and care coordination. The pain service is a little better maybe at pain, and their focus is symptom management and hospice and advanced care planning. And our focus is on the more complex forms of depression and anxiety and whether there was a psychiatric disorder before. So we're a little more on the disorder and complex if there's combined substance abuse, that kind of thing. So, but there's plenty of room, and we often work together. So when I first got to the NIH in the 2000s, there started to be a couple of papers about children and how they were suffering from cancer. And because more of them are surviving, this was a paper by Joanne Wolfe, who was a leader in pediatric palliative care. And she's focused on symptom management of children. And so she asked the parents to rate the symptoms that the children had in their cancer. And you see they all had fatigue, they all had pain, they all had difficulty breathing. Many of them had GI symptoms. But look, a lot of them were not calm or peaceful most of the time. A lot, more than half, are more than a little sad, having no fun, and were often afraid. So she put it out there that these kids are having a lot of psychological issues, and what are we doing about it? There is actually a biological basis for many of these symptoms, and as Stanley was just saying to me, well, HIV has so much anxiety and depression. Well, guess what? If we disrupt your cytokines, we're going to cause some symptoms. And if, for instance, we inject you with lipopolysaccharide as a healthy person, we will make you look depressed. We will cause you to have a fever. We make you feel tired. We'll make you be achy and have no concentration and feel not hungry and not be able to sleep well and just be depressed. And you will look like a depressed person from an inflammatory model. So this is why you see a lot of discussion about inflammation and depression, because it does partially fit the model for some types of depression. Now there is psychological depression as well, and we can talk about that a bit later. But so where do we come in? Lots of adolescents diagnosed with cancer have clinically significant anxiety and depression, but everyone would say, well, of course they do. They have cancer. But it isn't true that every patient that has cancer gets a full-blown depression. So that's where the special psychiatrist has to come in and kind of really tease this out. Because if we just went on those physical symptoms, sleeping and not eating, that's everyone who has cancer, because they're all having an inflammatory response. What we want to see, if we really want to figure out if they're depressed, is are they feeling guilty? Are they feeling like a burden? It's the psychological symptoms of depression, not just the physical symptoms. So you have to distinguish. So many survivors now have been shown to be at high risk for depression, anxiety, and attention deficit symptoms compared to siblings, as well as some antisocial behaviors. And then cancer survivors may be at risk for suicide attempts later in life. And I will say that's part of what got me into suicide risk screening separate from depression screening. So this population, when he did this study, Chris Reglitis, he found a group of patients who were screened on depression screens and were 0, but then they were suicidal. So in our work, we have shown you will miss 28% of suicidal people by using simply a depression screen. The general question that's being used is the PHQ-9, which has the 9th question, which is, are you having thoughts about wishing you were dead or hurting yourself? So that's a terrible question, because if you say yes, you don't know, are they thinking about being dead or are they thinking about hurting themselves? And for kids, hurting themselves is not the same thing as killing themselves. We know there are lots of kids who just hurt themselves without wanting to die. So it's the terrible question. That's the question that's out there. We advocate using our separate screen. It's called the Ask. So if you want to get into that, that's something separate. So when I met Lori at the NIH, she had worked on a therapeutic workbook for children, and it was called This Is My World, and it was to talk with chronically ill kids about things that bothered them and who would they talk to. And one of the kids told her, well, one thing that's missing from this workbook is a mock will. This 12-year-old said this to her. And she said, we kids think about this. So Stanley said, well, the kids don't think about this, but it's not actually true. Kids do think about this. And I got there, and this questionnaire, this is a mandala where we have the children draw their feelings and ask questions about what they think about their illness. And so this child wrote, when will I start getting sick again? What will happen to me tomorrow? What will it feel like to no longer exist? Will there be a cure? When will I die? Will I live long enough to go to high school, college, or get married? So kids are thinking about these things. And what happened to me is I met a 19-year-old girl who had to drop out of college because she had Ewing sarcoma and she had recurred. And she started telling me that, when she has her wake, she wants this music played and she wants these people invited. And I said, really? And she said, yeah, everybody plans their wake in high school. And I said, really? Because I was a pediatrician, and I don't remember that being in one of our anticipatory guidance lessons. So I started being curious. Do kids think about it? I started asking every kid I saw, what do you think about this? So I think that kids who have been exposed, and nowadays it's virtually impossible not to be exposed, if there's a death in your high school, or you had to go to a funeral yourself, or on the first day of my daughter's high school, a kid died in a car crash. and the star of the football team. So if that's happened to you, those kids probably do think about it, and it's not abnormal. It's not crazy to think about that. So kids think about it now. I would say if I had to redo that study now, I think that it would even be higher because of all the suicides that are going on. But so that started us thinking about this together. And so we realized, now our work started in about 2005-06. And we realized that there were no for adolescents who had cancers, they were really not, their mortality rate was still high. So Ewing sarcoma is still has the highest mortality of those cancers I showed you. And every year, 11,000 young adults and adolescents between the ages of 15 and 34 die from cancer and other conditions. And the Academy of Pediatrics and the IOM and the WHO all came out saying we need to include youth in their decision-making as they're developmentally and emotionally ready. So, well, what does that really mean? So I worked with a lot of adolescents who acquired their HIV behaviorally. Through having sex, when I was at Children's. And those kids definitely wanted to be involved in their care, and they knew, and in those days it was still kind of a lethal disease, not like now where it is a chronic disease. They had definite ideas about whether they wanted more treatment or not. So that really got us thinking, how can we make some kind of resource for children based on things that might have been available for adults? Which is how we always do it, right? We take things from adults and work it back. So we started a study, and we wanted to explore whether students, adolescents, and young adults living with life-limiting illness would be interested in a developmentally appropriate end-of-life planning document. So this was the document that exists for adults. It's a legal document in 45 states. I think you can use it as your advanced care planning guide. You can download this it was from a project called Aging with Dignity. And so we wanted to see if adolescents would find something like this useful to them. And would they find it stressful to complete, and what would they think we should include in something like that? So 5 Wishes talks to you about the person I want to make care decisions for me when I can't, the kind of medical treatments I want or don't want, how comfortable I want to be, how I want people to treat me, and what I want my loved ones to know. It has areas in it like in a coma and not expected to wake up and recover. I want life support, I don't want life support. I want life support if my doctor believes it could help, but I want my doctor to stop life support if it's not helping my health condition or symptoms. So even adolescents can understand this. And they have it as a checkbox, and then they want you to cross out the things you don't want. So this is my wish for how I want people to treat me. I wish people would be with me when it seems like my death might come, or if I'm not able to control my bowel or bladder functions, I wish for clothes and bed linens to be kept clean for them as they can be changed as soon as they can be. I want to die at home if that can be done. So in this adult version, you cross out or circle the things that you agree with. But the kids didn't really like that part of it. So now we didn't just throw this at any kids. We did have a readiness exam, and the readiness exam was in chronically ill kids with HIV or cancer. It might be helpful for me to talk about what would happen if treatments were no longer effective. Yes. Talking about medical care plans ahead of time to make sure my wishes are followed in case treatment options are limited or there are no more options available would upset me very much. So if you say, yes, it's going to upset me, then we're not doing this study to you. So, and I feel comfortable writing down or discussing what I want to happen to me if treatments are no longer effective. So the child has to say yes. So we had focus groups between our area and some kids at Georgetown. This is at the NCI students, participants, and they were between 16 and 28. And we asked them, would they find something like this helpful to themselves or another? Would they think that this would be helpful to kids? Not asking them to fill it out, just is this a concept okay to do? And would it be appropriate to ask either themselves or other kids, and how stressful would it be to complete this? And so they were also asked to rate the wishes and to see which were most helpful and least helpful, and which statements were should be added or subtracted. So we didn't ask them to fill it out themselves, we just asked them to look at this document and talk about it as if it were for other people. That's how we started. So 100% of them reported it would be appropriate for adolescents and young adults living with a serious illness. And how helpful would it be having such a document for yourself? Most people thought it would be very helpful, and a few thought it wouldn't be helpful. So then when we did a couple different iterations of this, and I'm condensing this because I don't want to keep you up all night, but what ultimately came, we had a second set of focus groups and asked similar questions, and then what came out of it, we had a qualitative section of it, and we asked them, what needs to be in this? And they said, well, you need to add where I want to be at the end of my life, when the end of my life is near, and the people I would like to have near me, the clothes I want to wear, the family and friends who would like to attend the service, the music I would like. We need a place to describe spiritual references, because in this document it's kind of scattered throughout, and you either check it or don't check it. It doesn't let you write what you want to say. The people who I would like to receive my belongings, so kids are thinking about this, and how I would like to be remembered on my birthday by my family or friends or on a holiday. So, and a place for letter writing. So when we talked to the kids, we realized what was missing were the developmental, what was missing were the developmental considerations. That's okay. And basically back to Erickson, right? So independence, identity, intimacy are the things that the kids are worried about. But kids are not married yet and don't have children yet, so this document does not fulfill what they need, right? So they needed a section on friends. I mean, it was very geared toward their adolescent issues. Death is the ultimate challenge to all these processes because it's their loss of identity, so they haven't even formed their identity and they're losing it. So they're very concerned with that, and that's where the title of the talk comes from, Will You Remember Me? Because I haven't done anything to be remembered by yet, was what we were hearing from the kids. So, and of course the demise of independence, which is really frustrating to them, and the end of any intimacy they might be just starting. So this is the dignity model, which is an end-of-life model. It's a narrative model. It is a therapy that Harvey Chachanov devised, and it's actually for anyone sort of close to the end of life that wants to talk about the issues that matter, and they record you giving a narrative about yourself and talking about things that what makes you feel your sense of self-worth despite any physical limitations. What's the legacy you would like? How do you still be me even when you're sick? How do you get control on your own terms? And how do you role preserve within having an illness? Maintaining hope, seeing that life has enduring and meaningful aspects to it despite death approaching, and also trying to live in the moment, worrying less about the future and trying to create a record of now. So we work with the kids in these areas. And what we ultimately came up with this document that we passed around a copy of is called Voicing My Choices. So just to tell you how it works, we made 5 wishes, then we made the intermediate document was called My Thoughts, My Wishes, My Voice, because we were trying to give a voice to the kids, and we were trying to stick with this issue of the wishes. And then when in the focus groups, the wishes were, the kids said, well, it's not our wish to die. That's a terrible name. So we said, okay, we're changing the name. So then the name was My Choices, My Voices, and then that turned out to be trademarked already, so then we ended up with Voicing My Choices, which is a great title, actually. So, we did this work between 2006 and 2008. And of course, maybe many of you recognize Sherwin Newland's book, How We Die. He wrote that, and he was a surgeon who wrote it in the 60s. It's a very detailed blow by blow of how people die. It's not a pretty book. Dying a respiratory death is not pretty. But after we came out with this document, these books came out in the popular press. There was the movie, The Fault in Our Stars, which was about kids having cancer and meeting each other, with the Brittany Maynard was on the cover of People, My Wish to Die, My Decision to Die. So it's been very much in the press after we came out with our document. And you can see several websites. So join CAKE, Your Love, Your Life, Your Legacy. CAKE, I don't know why they call it CAKE, is the easiest way to discover, to share, and store your end-of-life preferences. They have the Conversation Project many people promote when it comes to end-of-life care. One conversation can make the difference. death cafe, death over dinner. So it populated all of a sudden all over the internet, which was interesting. Even Facebook, just so you know, has a legacy statement about who do you want to control your Facebook pages when you're not here to control them. Do you want them frozen? Do you want somebody else to control it? So you'd better take a look at all these things. So otherwise it won't be memorialized unless you say something to someone. All right, so how do we approach advanced care planning? We think that you need to develop a standardized message and do it consistently and get used to doing it. And you need a team approach. It's best if it's done by the person who knows the patient the best and has a trusting relationship with them and maintains a familiarity with all of their specific needs. And when we get asked a lot to approach. So this is the key here. Prognosis is not necessary to initiate the discussion. It's quite frankly better if the prognosis is kind of distant, because otherwise it's too pressing. So now when you're feeling good is the time to have it. So many times it happened to me that I was with a mom sitting in the ICU and she turns to me and says, I don't know what my 17-year-old wants. We never discussed it. And now the child's too sick to discuss it. If you're really in the terminal aspects of your illness, you don't have the energy to do anything more than breathe, and barely that, and just exist. You're not thinking about how you want things to go. It's too much cognitive energy. So this is really something to do better, when the patient is relatively stable and not in a crisis, and it's just a conversation about what they want. Time of relapse and hospitalizations tends to be when it happens, because then you get nervous and you think, oh, I better have this conversation. But those are not actually the best times. It's better to do it as an outpatient and everybody's feeling well. And just remind them that families get nervous, but it's really to provide and respect the individual wishes of the child. Of course, in the end, the parent has the say, but you'd like to at least have heard what the child thought about it, whether you decide to honor that or not. So this is I told you that we check to see if the kid is ready, but why doesn't more of this happen? It's because you're not ready. You, the healthcare provider, need a readiness assessment. So when you see a kid and you think, I wouldn't be surprised if this child died soon due to their life-limiting illness, or within the year, or within this episode of care, we have those kids. We know it could happen this time. And do you know what the family's wishes are and the child's wishes are? If you don't know the answer to any of these, really, really, you should think about addressing these. How do you start the conversation? So ask who's involved in the care, because a lot of times pediatric palliative care is already involved and you don't have to get involved, so you can breathe a sigh of relief. But sometimes it's not that hard. So one of the things, Lori wrote it, we did this research to help give the kids a voice. I wrote it to help give physicians a voice. I trained as a pediatrician. I know that the pediatricians, we don't know how to do this, we don't want to do this, kids don't die, they're not supposed to die. So we're not eager to do this. So I wanted to give them the words because of course the child's like, I just know exactly what to say all the time. No. But so we practice the words, and has anyone had a discussion with you about what you would like to happen if your child becomes seriously ill? It's not that hard. So in light of what we've been talking about, what are your worries? Although we were hoping this medicine will be helpful, many people your age have told us they found it helpful to say what they would like or not like if treatment doesn't go well. Now, this is where research really helps you out. You say, other kids have told us this. We did the research on this, and that makes people feel better. So you say, in fact, people your age helped create the guide so they could put things down on paper that they wanted, what's important to them and what they want to control. So, as you see the pages, it's also can be done modularly. You don't have to do the whole book. You don't just hand the book to the kid and say, have at it. You have a discussion with the book. The book is a guide for you as the provider to kind of walk through it with the patient. And it's not written in stone. It's not a legal document. The person can change. They should be reassured they can change it anytime they want to change it. It is okay to let them fill parts out independently, but we really recommend they do it with a healthcare provider, especially because some of the medical parts are a little more explicit. So this is just an example page. You've already seen it, but so we start with how do people want to be comforted? And we do workshops on this, so we help physicians practice. And so we say, well, when you don't feel well, what tends to bring you the most comfort? Do you want the room dark? Do you want to listen to music? Are there certain clothes you find comforting? This is a page where you can share. So what the kids said were, we like the check boxes, but we want spaces to write our own things too. So they want to express their own individuality. They're not just about checking things. So every page has both check boxes and lines on it. And then how I wish to be remembered. Kids actually are not afraid of the autopsy question. They are not afraid of talking about burial versus cremation. Not every kid, obviously, and you have to go through the parent and the team that knows the person the best. But all of us have thought about what would happen to us if we died. Many of us, or most of us, have played out a funeral in our minds. Who would we want there or not there? What we would want people to say. There is nothing crazy about thinking about this. So here's your opportunity to say what you think is most important. Many people have shared they want something positive to come from their suffering. So these kids participate in research because they want something to come from their misery and for other people to learn something from something terrible that's happened to them. So do you have thoughts like this? Do you want doctors to learn from your tumors and cells so other kids who have the same disease can learn? So kids are pretty altruistic, and that's how we get so many kids in research also. Okay, so what happens if we don't talk about this? We get this, right? And this. So there are times, I know, the thing about having the kids, so the parents might not want to be the ones. They're reluctant. It might indicate they're not hopeful anymore. They don't want to let the kid have a message. So it doesn't have to be the kid. So that's why the document's nice, because it could be a third party. Parents are very relieved when they know someone's getting the information. They don't want to be the one getting the information necessarily, but they're happy that, and they think doctors and nurses should be the ones to do it. So, and then, it's hard when the teen and the family change their minds a lot, but that happens, and that's okay. You just keep changing it. And then parents don't want to let their teens be involved. So I always love when I'm in the interview. I always interview kids and parents together. And then I have the parent, they're looking at me and they're going, they don't know they were the product of a rape. I'm thinking, yeah, right. They're sitting right there in the room. But parents, little pitchers have big ears. They hear the parents talking on the phone about their cancer treatments. It's not like kids. I had kids who were 12 who were getting HIV treatment for years, and the mother was like, we're not telling the kid I had HIV because that's the way the kid got it perinatally. But the kids, if you talk to the kids, they say, yeah, I have HIV. I looked it up, So why else would I be taking these medicines? So kids know a lot of things. You just have to ask them what they know. And then sometimes there's problems because the physicians, the patients, and the parents all have a different understanding of where we're going. So I know we at the NIH never want to talk about the child dying because we're all about the cure. We're all about the treatment. But sometimes we just can't beat it. And, is it really worth... Okay, and I don't know what I would do if this was my child. They're six when they get their leukemia. Now they're 13. They've had leukemia their whole life. They've had 2 bone marrow transplants. Now they're coming for CAR T-cell, which will only get them to the next bone marrow transplant. It's not a final treatment. It's not a cure. So when you're 13 and you've been fighting this for 6 years and you've spent your whole life in the hospital, is that, some kids get tired. Actually, and it's worth talking to them a little bit, but it's hard because, we never say die at our hospital. So, and sometimes even the the team can be divided, and sometimes it's too late and people are concerned about taking away hope, but kids want the same thing as adults want. They don't want to be abandoned, and they don't want to be in pain. And they want to know they're loved. So it's all the same. And, thinking about previous losses, cultural, spiritual beliefs are important. This is the hardest part, transitioning from curative intent to end-of-life care, trying to make them comfortable, let them just skip that one more bone marrow so they can go to Disney World, for their last trip. So we have to help them. We've written several papers on this, and I'd like to say that one of the most gratifying parts about working at the NIH is that we do have a platform, and we have created standards of psychosocial care for pediatric patients with cancer. There are 15 of them. One of them is actually a palliative care and end of care life care, and that families should be introduced to this idea regardless of their disease status through the process. And we have evidence from 36, all of these things are evidence-based, these 15 standards. The standards were all published in the Pediatric Blood and Cancer Journal from December 2015, and all the evidence for these things were there. So I'll just finish here. This young lady was has a primary immunodeficiency GATA2, and she was facing a bone marrow transplant. Her sister had already died of a bone marrow transplant for this same disease. And her sister had done Voicing My Choices. She elected to do Voicing My Choices. It made it to the front page above the fold on the New York Times. She's now a physical therapist, and she's doing great. So you can do the thing. It doesn't have to come to pass, but she at least had made her wishes known at the time, what she wanted, because her sister had not done that. So it's not, it's really something to let kids have a say in their care. So she's doing great, and that's that. So thank you.